All right, thank you very much, Mike. So we did open the meeting, and we did have a closed session that we had to deal with under Section 239 of the Municipal Act that dealt on negotiations. And so now to the members, is there any disclosure of pecuniary interest on the agenda as presented to you this afternoon? None. Okay, we'll have that duly noted. And so we'll move on to 4.0, and that's our update with Dr. Nezaturi, and it's on the COVID-19 update.
Board Chair, Mr. McNamara, members of the Board of Health, colleagues, thank you so much for the opportunity to speak today. I just want to make a few brief remarks. Since the last time we met at the Board of Health, disease activity has increased. Currently, we have about 137 cases per 100,000 people. We have 483 deaths. We have 41 people in the hospital, and we have 32 outbreaks. So it's pretty clear that disease activity in the health district has increased. When we look at death, which is death and hospitalization, it's fair to characterize COVID as affecting two populations or two parts of our community. And I had a chance to speak to one of the senior intensivists today just to reflect on the Windsor-Essex experience. So in the deaths, and we've had about 45 deaths since August of this year. Of the deaths, 2/3 of the deaths are among people that are vaccinated, who are unvaccinated. So 2/3 of the deaths are among the unvaccinated, despite the fact that they constitute probably 20% of the population, maybe a bit less than that. And the other 1/3 of the deaths are in people that are vaccinated, but have serious medical problems. You know, in medicine, we talk about premature and non-premature deaths. Many of these deaths are premature deaths. These are people who typically would have lived many, many years, save for the fact they got COVID. Among the people who are vaccinated who've had COVID, and without naming any one individual, but presenting the vignette, a typical vignette might be a 65-year-old man who has lymphoma, which is treated, and one can live for many, many years with treated lymphoma. Or the woman in her 50s or 60s who has a kidney transplant and is on immunosuppressive medicines. Both of those people will likely have got vaccinated, but they can't mount a perfect response to the vaccine. And if they get COVID, they're more likely to suffer from the adverse consequences. In Windsor-Essex, and I'm just looking at my notes here, speaking to the intensivists, 30 to 50% of the beds currently in the units are occupied by people who have COVID-related diseases or COVID-related admissions. Why is this important? Well, it's important because it's a human tragedy, because people who can live are dying. And they're dying at a rate that exceeds the deaths we might see in car crashes. Secondly, it has population health challenges, because if we are focusing our resources on treating people with COVID in the ICU, that means that we can't treat people with other disease states in the hospital. So it crowds out other important health services. And one of the hidden consequences of the pandemic is not only has it affected people with COVID, but it's affected people who don't have COVID but have medical problems, where they don't have access to their doctors and the hospital and screening services and timely medical treatment. My second point is I'd like to just talk about what the strategy has been up to this point. So the strategy for managing COVID, and it's a healthcare-wide and community-wide strategy, is first is containment. So containment is every time you identify a case of COVID-19, to try to contain it to that one person or that one household and try to prevent it spread from person to person to person. And that is sort of the cornerstone of public health practice. We use containment for other disease states, namely sexually transmitted infections, tuberculosis. where we do our best as a public health service to contain the disease and prevent its spread to others. And the second part of the strategy for COVID-19 is vaccination. And vaccination has an individual level benefit to the extent that if you're vaccinated, you're much less likely to get sick and die of COVID. Now, speaking to the intensivist today, he had pointed out to me that virtually no one who's healthy and vaccinated is dying from COVID. So if you're healthy and you get vaccinated, you're not likely to get sick from COVID in any significant way. And so vaccination has individual level benefit, and vaccination has population health benefit, because if you're vaccinated, you're less likely to get COVID, and if you get COVID, you're less likely to give it to somebody else. So our strategy up to this point has been a two-tier strategy, or a two-pronged strategy. The first is containment, and the second is vaccination. The Ministry of Health has directed us to shift resources from containment to vaccination. It's a public health strategy where we think will have a greater benefit to the population to get people vaccinated. And that means the reassignment or the reprioritization of staff resources to the vaccination effort. What that means, though, is that we also have to think of the consequence of that strategy. Is the people who most benefit from containment at this current time are those individuals who are currently not vaccinated. Because if you're not vaccinated, you don't get the benefit of the vaccine, which means the only public health strategy that you benefit from is containment, breaking the chain of transmission. And so in the short period of time, a public health measure that disproportionately benefits the unvaccinated is going to be diminished a bit. The second issue is that when we shift from away from organized containment by the public health service, that means that the community members will have to participate more boldly and more thoroughly in the containment effort. Meaning this: if you are diagnosed with COVID, the new approach is going to be that you as an individual will have to reach out and speak to all your close contacts and tell them to self-isolate. Now, historically, the public health service has managed that process. And as we have diminished resources for case and contact management or containment strategies, that will mean there'll be a greater burden on community members to effectuate the case and contact management process. That is a trade-off. Like everything else we do in public service, we make trade-offs, and that's a trade-off that the Ministry of Health has recognizes and asked us to do. The public health service will provide resources to help people on the web page and in other ways to help people with effectuating containment if in fact they have been exposed or if they have contracted COVID-19. The third point I want to close with is we have this, now that we have this strategy to push forward with vaccination, the magnitude of that request is profound. It's staggering. Just in the back of an envelope calculation, at this point, 340,000 people in the health district have received one dose of the vaccine. And we have to get 3 doses into people. So hundreds of thousands of people at some point in time will need to be vaccinated in short order. We're currently focusing on people 50 and above, but there will be a greater eligibility for that 3rd dose of vaccine starting in January. So what does that mean? Windsor-Essex, I think pretty clearly has done a good job with vaccine availability. It has its community vaccination center, otherwise known as a mass vaccination center, has pharmacies, some physicians' offices, and was able to perhaps vaccinate 2,000, 2,500 people a day. But really, if we want to vaccinate, let's use a rough number, 300,000 people in a short period of time, even at 6,000 people a day, that's 50 days. And we know that the Omicron variant is posing a greater challenge to the health system. So to that extent, the staff at the Public Health Service have really reached out to exhaust every channel for to increase vaccine availability. So that includes the mass vaccination center to try to build that up. The Public Health Service has reached out to family physicians. I was on the phone just earlier today with the dean of the local medical school campus. He's offered the resources of the medical students, which I think would be a wonderful resource. We're going to reach out to dental surgeons and anyone who has the ability to help with vaccine distribution. We should exhaust every possible channel of distribution to get as many people vaccinated as quickly as possible. My ask, and if Board Chair Master and Mr. McNamara, if this is okay, my ask is for Board of Health members to continue to amplify the message that those individuals who are eligible for vaccine get it as quickly as possible, as they're eligible, to have dialogue with those people who are currently not vaccinated to get vaccinated and start the vaccination process, and continue to work together to try to effectuate the best possible public health plan for the people of Windsor-Essex. So thank you so much for letting me speak today. I'm happy to answer any questions or provide some clarifications.
All right, thank you very much to our Medical Officer of Health, Dr. Nazatiri. Is there any questions or comments that we'd like to bring forward? I have one question, and Nicole, I know you've answered one of our communities about clarification about what is a gathering and what is a team sport, and then the confusion for some is if it's a team sport, the arenas, there's they can still have their the hockey game and so forth. But if it's a group of individuals that just want to get together and pick up hockey and so forth, that's more of a gathering than a team sport. And I think there's a little bit of confusion with folks who feel that if there's a hockey team versus pickup group that just want to rent the ice for an hour and so forth. I think we need to to make sure that we clarify that. So how would you certainly address folks in separating that in the rationale why one is more of a gathering versus that team sport piece?
So Eric's on as well, and he does deal with a lot of our FAQs related to both the Reopening Ontario Act, but also our letters of instructions. I have to, we will provide clarification, and as we get questions, we will put FAQs up. We also have to be careful. Some of the definitions that we rely on are actually definitions that are in the ROA. So they're under the Reopening Ontario Act because it does restrict like those social gatherings are defined. It's always difficult trying to, it's also open, it's
open to interpretation.
It is open to interpretation. So we've had this all along during the pandemic where one region or a bylaw might see it one way or one legal opinion about how something might be, how they're going to interpret something or enforce something versus another region. We do work very closely with all our police, OPP bylaw officers, as well as our own enforcement, and they meet every 2 weeks. And so these types of things are raised to make sure that we're all, for the most part, interpreting things the same way or applying things the same way. But it's also difficult when you have an officer will also have their own opinion about what they believe might be a social gathering or qualify as a social gathering versus some other type of activity. So it is sometimes difficult to be like 100% clear in those circumstances. But there are definitions around organized sport and recreation in the Reopening Ontario Act, and I think that's what you're relying on, is what is defined as organized sport and recreation versus what is not.
I think, you know, for some of the folks, there's a confusion out there, and that puts a lot of misinformation. And even for those from one community to the next, whether it's you know, the different branches of the Ontario Provincial Police or the you know, Windsor Amherstburg group in LaSalle, it's the difference in interpretation, and I think that spurs a lot of the false information. That's where we get a lot of the phone calls, and you know, how come they're doing it there and they can't do it here, and why is allowed in this municipality, not there, and a lot of times we can't give them an answer, right? Because really, I don't know what's happening in Kingsville, for example, versus Tecumseh, or for that matter, in Windsor, and so on and so forth. And is there any way that we can get the province to more, you know, to get more clarity in terms of making more black and white than gray? And you know, again, individuals are always trying to find holes in you know, in the regulations or in the rules of engagement, and that makes it very difficult.
Mr. Board Chair, Mr. McNamara, Mr. McNamara, is it okay if I supplement Nicole's perspective?
Yeah, I mean, I suppose on individuals, you know, as an engineer, it's black and white, and Ned's an engineer as well. It's logic, and it's you know, it's black and white. It works or it doesn't work, and I think that's what makes it difficult. But I think the information that has to, you know, that whether it's on you know, that's coming out of public health, maybe what we can do in the municipality through our own websites and others is just, you know, have a continuity within the messaging.
Yeah, I think that first of all, there are apparent inconsistencies. We acknowledge that there are apparent inconsistencies, and part of that is there's no easy way to codify all human activity, and regrettably, the pandemic has made us impose restrictions and curtail human activity in such an expansive way that it leads to inconsistencies. I think I acknowledge that, and I think many members of the Public Health Service acknowledge that between how the different rules should apply or not apply. The second is that we, as medical officers of health, have asked the province on a number of occasions to act in a more province-wide framework as opposed to health district by health district. And I remain optimistic that the province will ultimately provide more uniform public health measures as opposed to where we are today, exactly for issues like people traveling from Chatham-Kent or traveling from Sarnia to Windsor. It's hard to keep, it is challenging to know what rules apply at which time in which district, and that's an area of opportunity, I think, for the Public Health Service throughout the province for sure. So thank you for allowing me to comment on that.
Oh, yeah, I guess I'll just add that we continue to add FAQs, where it's our direction, we'll provide clarity about our direction when it comes to the ROA. Again, we do meet every 2 weeks, and like I said, Eric is on and can probably speak more to that, but we do meet every 2 weeks with the regional enforcement, because, you know, each area has their own legal counsel that reads the ROA, and unfortunately, it's not all black and white, it is gray, and many cases are individual. And I think you made a point around loopholes, and I think that's why it's a little bit gray, is that it's not everything is as clear. And so it is, you know, up to, you know, the institution to interpret, and also up to the municipality to interpret. And then for us, we do our, you know, we have our own interpretation, and we're always very clear with our municipal partners, for example, that this is our interpretation of the Reopening Ontario Act, or our legal interpretation, and they may have their own, their legal may have their own interpretation. And as well, there are instances where, a municipality might be more comfortable with a certain, you know what I mean? So they may be more comfortable with, this is how we're interpreting it, and this is the approach that we want to take as a community. But that group does come together and tries to, at least be clear that we're enforcing things the same way. And certainly when municipalities or any member of the public reaches out to us, we'll do our best to explain, again, based on our interpretation of the Reopening Ontario Act and what we believe, how a certain situation it may apply. But it is challenging, and I think sometimes we get people will take one scenario and then apply it to multiple, and it doesn't always work. It doesn't always work that way.
Then I guess to the point, and Eric, I know that you're at the point person on that, but you're meeting every other week now, or every 2 weeks on the enforcement piece and so forth. But now it's with Omicron, being kind of now at the front of the issue at hand and so forth. And as things now you're seeing the province acting a bit stronger. You see the feds are acting a little bit stronger and locally and so forth. Now, is it a resource, human capital issue on the enforcement piece every other week? Is there a time now saying, ooh, maybe we should be thinking about once a week we should be getting together? Or do you think that we're still, in pretty good hands to say every other week?
Yeah, I wouldn't say necessarily that it would be a resource issue in terms of the meeting frequency, because we can always meet more frequently, and in fact have met multiple times a week in different stages of the pandemic. This group's gone back probably almost a year now, and the health unit has chaired it for this very purpose. And sadly, it is very difficult between enforcement agencies to have a consistent interpretation across, especially with new legislation that at different points during the pandemic has changed on almost a daily basis. So meeting frequency is one thing, but communication in between meetings is ongoing as well. And one thing that one of the members, I believe from the solicitor's office in Amherstburg, actually has been doing for the last little while is collating all of the different pieces of legislation into one cohesive document, and has integrated even our letters of instruction and our Section 22 orders into that document. And that's something that's provided out to the group as well. So there's a few different pieces. I mean, meeting frequency is one thing, but ongoing communication between our officers and the officers in, Tecumseh, Windsor, and in police services, that is ongoing. Those partnerships have been maintained for well over a year now. So I don't know that meeting frequency is necessarily the issue. The other thing that I will say is that we have sought provincial support from what's called a multi-ministry agency, that basically any provincial ministry that has enforcement officers that are available to support enforcement efforts have come down on multiple occasions over the course of the pandemic, and we are working on an additional one now that will be reflective of the letter of instruction and some of the new capacity limits that have been brought forward by the province. So that is ongoing.
Well, thanks for that, because I think that was the point they're trying to make as well, is that there's all kinds of activity that's happening behind the scenes that the general population it really doesn't know, and I think that's the point I was trying to make as well. Any further questions or sort of comments to be brought forward? If not,
Larry has his hand up.
Yeah, through the chair to the doctor. This latest strain that's out there, the Omicron, I'm getting a lot of mixed information on this latest one. A lot of people are saying that this one here is not as strong as the previous. Are they right or wrong there? Because I'm hearing from a lot of people out there on public right now on the streets that they're saying that this last strain here that's out right now is nothing more than the flu. Can you just speak on that, please? How's that compared to the previous variant, Delta variant?
Right. You know, I think that the answer to that question, if I could just offer some context, we don't really have our knowledge of the different variants is still evolving. COVID's a new disease. These variants are new variants. On an individual level, I think the best evidence suggests that the vast majority of people who get COVID make a recovery from it. And for many people who are vaccinated, they're likely to have a mild to moderate. If they get COVID, they're going to have a mild to moderate illness. And it's unlikely that any healthy vaccinated person, so someone who doesn't have serious medical comorbidity, is going to die from COVID. I think that's going to be pretty unlikely. For unvaccinated people, I think that they too are going to get COVID and likely have a spectrum of illness. But I think the spectrum of illness is going to be more severe, is likely to be more severe in people that are unvaccinated. So an unvaccinated person who gets COVID, I think, is more likely to be hospitalized and more likely to die from it, more likely to be put on a ventilator. So that's sort of the individual level challenge. Now, at a population health level challenge, which is thinking of it of the disease in the aggregate, it's thought that Omicron is likely to infect more people. So one infected person is thought to infect more people than the Delta variant. So what that means is that at a population health level, there are going to be more people who are sick. And if there are more people who are sick, who have mild, moderate, severe disease, then there's also going to be more people with severe disease and more people hospitalized and more people dying. So that's sort of where I'd put it from an individual and population health level. But I think that on an individual level, if you're vaccinated, you're going to suffer. If you do get COVID, you're going to have you won't. Doctors loathe predicting the future, but you're not likely to be hospitalized or die if you've been vaccinated. My intensivist colleague would go a little bit further and say that he would be surprised if you died if you were vaccinated. So I hope that provides some context. I don't think we can conclude that this variant of the virus for most people is going to be more severe or less severe on an individual basis than the previous virus or the previous variant. I hope that answers the question, Mr. Snively.
Yeah, it does. Thank you very much, Doctor. And I think this has got to get out to the public more, how important it is to get vaccinated. And we're all on the same page here. Well, I'm still got the mic here. One quick question to the chair. Through the vaccine at the mall, is that a walk-in or is that you have to register for that?
You have to register, and then you do have the choice between Pfizer and Moderna.
Okay, thank you.
Okay, Ed, and then Judy.
Thanks, Gary. Can you hear me?
Yes, we can.
That's great. By the way, this morning I was talking to one of our MPs, not the provincial, the federal MPs. And we talked about the virus and so on. He said something, he wasn't very clear, but he was saying the federal government are really concerned about the new virus coming up. And I don't know what is the concern. He mentioned the fact that maybe Dr. Shanker can explain it. He said it's about 4.5 to 5 times as contagious as the COVID-19. And so the government is looking after it, but I know that when it comes to health issue, usually we have the provincial government look after it. But this time he was saying they're really concerned about it. I asked the doctor if he can give us a comment on it.
Yeah, I am very concerned. The new variant or the Omicron variant is likely to infect more people for every case. So if you have Omicron, you're likely to infect more people than if you had the Delta. That's the theory that we're working under right now. We're seeing case counts go to a very significant level. I think that the province today, it was about 2,000 cases. So the case counts are going up. My biggest fear, if I have to think of the thing that keeps me up at night, would be that the hospital becomes saturated and doesn't have any more resources to admit people on the ventilators or people who need very significant care. So, and the reasons for that are, one, that if we have a larger group of people that are infected, that means there'll be a larger number of people presenting at the hospital, a larger number of people going to the ICU, and a larger number of people going on a ventilator. The second is I worry that if we start seeing penetration into hospital staff, if we start seeing hospital staff get infected, which is one of the concerns with any pandemic, then their capacity to operate will also be diminished. A hospital, for every bed in a hospital, I would hazard to say there are 4, 5, 6 staff at all levels doctors, nurses, therapists, housekeeping staff, dietary, administration. And if we start seeing a whole group of hospital staff getting sick because of the higher infectivity rate, that could cripple the hospital's ability to function. And that's the other thing that I think worries me. So we have good reason to worry, but also, like everything else, we have to pull all the levers that we can to try to control this, which is what I think that's why we're asking people to really participate in the vaccination program. If I could share, and sometimes I know I speak at length about this, there are the unvaccinated, but there's another group of people I would ask everyone to reach out to, and that's their family members who have chronic medical conditions. So if you know of a family member who's got cancer and has been treated, or has a kidney transplant and has been treated or on dialysis, make sure that they get the book for that third appointment if they're eligible for it, because they're the group of people that could really benefit beyond the unvaccinated with this additional booster vaccine. I hope that provides context, Mr. Slyman.
Doctor, thank you very much for the explanation. One of the concerns I have, I hope I am wrong, we're not heading into a complete lockdown, are we? Especially with the number of cases have been soaring up like crazy.
Yeah, so under the old rubric, at this level of burden of disease, we would be in lockdown, or if we use those words. I am concerned. I think all of us in the public health service are expressing concern. The thing that's different now is we have a new tool to control the disease, which is vaccine. And to me, there are many things in medicine we can't do anything about. If you have pancreatic cancer, you're going to die. Many brain tumors are ultimately going to take your life. But in this particular case, we have a treatment to offer people, and we just have to get the treatment out to them. And the other thing, and this is a personal thing, when I see some of the deaths, they're senseless deaths. They're people just like me who, if they got the vaccine, they would live. If it's safe for the vaccine, they would live. So from my vantage point, we need additional public health restrictions, but also I think that hopefully we can avoid having to have a complete lockdown as you characterize it.
Doctor, thank you so much. We appreciate it. We appreciate your input quite a bit, honestly. Thank you.
You're welcome. Thank you so much.
Thank you.
Judy? Oh, you're welcome. Judy?
Thank you, Gary. Thank you, Doctor. And as Ed said, I always really appreciate your very plain language explanations and making the case for vaccines. So Dr. Tam was talking earlier this week about, I know there's the urgency right now, but I think there's also a sense of somewhat feeling a little hopeless, even people who are getting vaccinated, because they're vaccinated, but still we keep seeing these new variants. And that the typical life, she talked about the typical life of a vaccine, of a virus like this, that that if we get that level of vaccination out to the population, that this will eventually, most likely, become something like the flu, where we have an annual flu shot and it is something that's manageable without, as Ed just said, shutting down the entire system again. Can you speak to that? Because I think, again, this time of year is very difficult for people. People are feeling very isolated. I know some people are just saying, look, I'm vaccinated, I'm taking my life back, where we're trying to encourage people. Yes, we still have to stay the course. It's just as bad. We've had a number of people really very recently, and as you're saying, pass away, very young or our ages, that feel very tragic, but that there will be light at the end of the tunnel. We are heading the right course, but we have to stay the course. Can you speak to that?
Sure, and my apologies for being long-winded on this. We have the immediate problem, which is how do we get through these next few weeks so that we can try to provide sufficient containment that we don't overwhelm the hospital and the public health and the health system. And I think that that's something that we have to work towards, recognizing that many of the public health measures benefit the unvaccinated. So I can give a concrete example. Part of our containment strategy is to dismiss young people from schools if there's an exposure. And about 800 cohorts of young people have been dismissed from school. That's, if 20 students are in a cohort, that's 16,000 young people have had their school interrupted for 10 days perhaps, or 5% of a school year, because we want to prevent the chain of transmission from them to their parent, to a grandparent, to either a vulnerable vaccinated person or an unvaccinated person. And so that's our strategy up to this point. And I think in the short term, we have to continue with these containment efforts. Over the long term, though, I think this is perfectly appropriate dialogue for the Board of Health and for the community overall. Do we shift to more of a management approach as opposed to a containment approach? So, meaning that we accept a certain number of deaths and hospitalizations with the flu, just like we accept a certain number of deaths and hospitalizations related to car crashes. So if I could use car crashes, which is, we have about 600 car crash deaths in the province every year. We have thousands of more hospitalizations. And we modulate public policy based on our level of acceptance. We can bring the number of car crashes down to 0 if no one drives a car. But obviously that's not practical. We could probably bring it down quite a bit if we had the speed limit at 10 miles an hour, but we choose not to do that. So we modulate speed limit, alcohol levels, enforcement to find the right place to balance the community interest for transportation with obviously the consequences of some people suffering and dying from car crashes. It's true with the flu as well. We have, and for containment for COVID may include a suite of measures. It may be an acceptance of a certain number of ICU admissions and hospitalizations. It may require that we wear a mask indefinitely indoors when we go out. It may mean that at restaurant dining is no longer a carefree task, but something we may only do in more limited circumstances. It may require that we, for the intermediate term, restrict the number of people that have the large outdoor gatherings and have enhanced social distancing. It may mean also that we vaccinate every 6 months or every year until we can have a handle on this. And just think of HIV. There'll be a day, I think, that we'll likely have antiviral drugs, just like we have for HIV, that when people do have an infection, we'll be able to also treat it and suppress its long-term sequelae. That requires us to have this more fulsome discussion when there's not an immediate public health emergency. But I do think that we have to think of what our plan moving forward should be. I also think, and this is something that we should have explicit dialogue on. I know there are 2 engineers on the Board of Health. Engineers always quantify risk relative to benefit as it relates to the construction of a bridge or construction of my house. You know, that my house would probably not withstand a 200-mile-an-hour tornado, but They don't plan for that. They accept that that's a pretty unlikely event. That's what we have to do as a culture. And I think that the point that you raise is an entirely reasonable one, and we should have a fulsome discussion. Not today, because today we have a real problem. But once we get control of this wave, I think we have to have that discussion moving forward. I'm sorry, Board of Health member Lund, for commenting so extensively on that, but I hope that provides context.
Yep. Thank you very much. And I agree that now isn't the day, but I do think it's important to have some comment on it so that people do feel, despite where we're at today and the urgency, we are moving forward and we are heading in a direction, and it will get there at one point. We don't know when that day is yet. People had hoped it was going to be a shorter period of time. It's clear that's not going to happen. Thank you.
Reno?
Thank you. I'm just following up with a comment Dr. Nazateri made about schools. I'm wondering, and I've heard just from parents, when we release the cohorts and there is class or potential exposure, that students are often off for either 10 days or sometimes 2 weeks, depending on 2 school weeks, I guess, depending on the class or whatever, and why we haven't looked into rapid testing. And just because the cohorts that get dismissed are extremely large, as you just mentioned, sometimes thousands and thousands of students for potential handful of actual cases. Is there a way that we could work? Is it just simply not having the tests? Is it a matter of cost? Is it a matter of process? If you could just speak to that.
Sure. So testing is complicated. So in medicine, we use tests for different reasons. Sometimes you use a test to figure out if someone has a disease. So if they have pancreatic cancer, we order a CAT scan. Sometimes we use tests to measure disease activity. So if you're being treated for leukemia, you may follow the blood counts, and you may get a test every week or every 2 weeks or every month. Sometimes use a test to see if someone's actually recovered from a disease. A very specialized form of testing is screening, meaning identifying people who don't have clinically apparent disease to see if in fact that they have the disease. Now, this is where it gets complicated, because screening is a different reason to do a test than for diagnosis or for testing someone for disease activity. Whenever one does a test, you have to think of the test itself. So it's sort of like an engineering construct. There is the actual functioning of the laboratory test under perfect circumstances. And then you have to take that information and decide how to apply that test to the community. So under perfect circumstances, in a group of people that are not symptomatic, the rapid antigen test is thought to be about 65, 67, 70% sensitive. Meaning this, if you flip a coin, that's 50% sensitivity. If you do the test, you're at 67% sensitivity. So most people in testing would say 67% doesn't really give you a very powerful test. So that's the first challenge with the test. But assuming that you're going to do the test, then you have to make a couple of strategic decisions. And these are public health decisions. One is, when you do a test with low background prevalence, meaning that you think it's very, very rare that someone who's going to get the test actually has the disease, then you will have a distribution. You'll have, in any population of people, if you have 200 people who you do a test on, and you test them with a test of this quality, most of the people who test positive will in fact not have the disease. So using crude numbers, if you were to test asymptomatic people, most of the people who test positive will not have the disease. And if most of the people don't have the disease, then you're disadvantaging people who don't have the disease with the consequences of your treatment. So as it relates to rapid antigen testing in children, It is true that rapid antigen testing will pick up children who have the disease, but it's likely to pick up many more children who don't have the disease. And so if the goal is to keep children in school, then you have to make a risk-benefit decision. Are you prepared to exclude 4 children who test positive who don't have the disease so that you prevent one person from going into the school who may have the disease? So that's sort of an academic question. Now, as it relates to test to stay, this is a Windsor-Essex, this is where the local context comes into play. The Public Health Service and the team have devoted a lot of resources for containment. So the first part of containment of the school is to keep the number of cases down in the community. If there's no one in the community has COVID, no one can penetrate into the school. Most of the penetrations into the school are related to people who've had COVID in the community and have breached the school perimeter. Once COVID is identified in a class, we want to prevent it from spreading like right through the school. If we see what happened at the Kingsville restaurant, the restaurant, 42 or 45 people ultimately got infected. So once it's penetrated through the school into a class, once it's in the class, we dismiss the class. Now, test to stay would mean that you would have to test those individuals and make a decision on who you bring back. If one of those tests to stay fails, that could mean the closure of a school, because then it would spread throughout the school. So it's a risk-benefit decision. I think the crude data, and we'll only know at the end of the pandemic, is despite the fact that there are 800 cohorts that have penetrated into schools, very few schools have closed in Windsor-Essex. I think it's only a handful. Nicole knows the numbers better than me. It's only a handful. So we have widespread disease activity in the community. We've identified in 800 cases where it's penetrated into the school, and those public health measures, which the school board has effectuated them quickly, means that very few schools have closed. Now, and this is a calculus, it's a judgment call based on the data. If we relax our measures and let people come back earlier than that 10-day period, we also take the chance of wiping out the school in its entirety. And that's my fear. That's the fear that I have about using test to stay. Now, if presented with numbers and different facts and circumstances, we obviously would consider that. The other question I get asked about is test at home versus test in the lab. If you're going to do a test, the best way to do a test is to execute on it perfectly. And right now in Windsor-Essex, there is good testing capacity. So if someone needs a test for medical reasons, it's best to test them where we have the professionals, we have the hospital, the testing centers, where we can test under perfect circumstances. Now, if at some point testing is not available or is saturated, then of course we'll consider other venues for testing as clinically appropriate. So anyway, Reno, I don't know your last name, so I have to call you Mr. Reno, but I'm happy to talk about it. But those are the considerations. Every option's on the table. And the Public Health Service is not married to any dogma. If we think it's going to make a difference based on the facts and circumstances in Windsor-Essex, we'll definitely do it. But we don't want to do anything that would diminish our strategy to keep kids in school. And to me, that is the #1 priority of the health district.
If I could just add, and given all of that, the current guidance from the ministry is to isolate. So when there's the all the students in a class are considered high-risk contacts. And the current guidance that we're following is that is for them to isolate for that period of 10 days and to obtain a PCR test at the assessment center.
Yeah, I think, Ed, you still have your hand up or you're good? Okay, you can lower the hand. Okay, no further comments. I think it all boils down to one thing, really. It's limit the collateral damage. It's, so I'm glad. I know this we certainly extended a lot of time on this, but I think it's important, and I only wish that, you know, the 50,000 people out there that are hesitant on vaccination would have the opportunity to listen in on this, in particular in this conversation. So I certainly agree with Judy's comments earlier. Dr. Nazateri, you brought it down to a level that, you know, it's understandable, and you know, for most folks. But I think that's it. Limit the amount of collateral damage, and how do we do that? Vaccination, number one, and personal responsibility. Judy?
Sorry, just thinking about the schools. My understanding is there are some tests going home with the children over the holidays. Is there any discussion about that being extended to childcare or daycare centers?
I'm not aware of going that expansion, but maybe perhaps Nicole can comment on that public policy.
Yeah, so those tests aren't, I mean, we're not sending them home. That's a provincial program, and we haven't been made aware of any expansion for daycare settings, no.
Okay, thank you.
Yeah, the one recommendation I'd say is, and I think the school boards are emphasizing this, is that the best way to prevent penetration after the school year, when the school year opens, is to keep your kids at home if they're sick. And the second is to avoid large parties and other events where you're having lots of human-to-human interaction. I think those activities will be more likely to prevent penetration within the school in the new year.
Okay, any further questions or comments? If not, if I could have a motion to receive Dr. Zateri's report. Judy moves, supported Larry, all in favor. Opposed, if any, that's carried. Thank you very much for that in-depth report and certainly discussion. Okay, approval of the minutes of the regular board meeting of November 18th. If I could have a motion on those minutes, Joe, thank you, move, and supported by Gary. Any errors or omission on those minutes as presented? Hearing none, all in favor? Opposed, if any, that is carried. Thank you. Business arising from that 6.1, the consumption and treatment services update. Nicole or Eric or both?
It'll be short and sweet, and Eric can add if he likes, but last time we had our board meeting, I think we mentioned our intention was to go forward for approval of the site that the board approved in October for December 20th council meeting, having been bumped from the November council meeting, and we did receive notification that we are been bumped again to January. So anyway, just wanted to give that update to the board. Although behind the scenes, Eric has been working really hard with our partners at CHC and others to complete the other components of the site, you know, the plans for the application that will be ultimately submitted once we are able to go forward and receive approval from the city of Windsor for the site. Anything you want to add, Eric?
The only thing I would add is that we are also, in addition to completing the application, we're also finalizing a number of different reports and materials to share with council, hopefully address their questions proactively, so that when we come, we'll have everybody will have a good baseline knowledge of what the sites are, what the plan is, and how we plan to move forward in terms of timelines for the application.
Okay. So stay tuned. Hopefully our January meeting will have something to report. All right, we'll move on to the consent agenda for information reports. Maybe I can just have a motion to receive those, and then I'll certainly circle back to the directors. There's something they want to highlight out of their report. So motion to receive the consent agenda. Judy and Reno, all in favor? Opposed, if any, that's carried. Eric, is there anything that you'd like to highlight on the Ontario Seniors Dental Program?
I'll keep it short and sweet. It's a relatively newer program. It's geared toward low-income seniors, and it's been operating now since the fall of 2019. And one of the programs that we've prioritized to maintain as much as possible during the pandemic. There was some closures in different periods. The one challenge right now is the massive interest in the program. And so there are some wait times that we have a couple of different initiatives that we're proposing within the report that we plan to implement to address those wait times.
Okay, thank you. Lori, I thought you were putting your hand up, or?
Oh, I can wait till Eric concludes. I apologize.
I think he is.
I just wanted to speak to the Q3 report. That's,
Oh, okay.
yeah, when that time rises.
Okay, I'll certainly get to you. 7.12 legacy for children parenting program. I think, Felicia, is there anything you want to highlight in your report?
Yes, thank you, Mr. Chair. And I'll try to keep it brief as well. I just wanted to inform the board that the WICHU will be launching the new evidence-based parenting program that's targeted towards low-income, low-resource mothers with infants and young children in the new year. Our current data, as you will see in the report, shows that 1 in 5 children in our jurisdiction lives in poverty. And we do know that children that live in low-income households are at a greater risk for poor outcomes related to growth and development. So with Legacy for Children Parenting Program, we're hoping to make a positive impact on the social and behavioral development of the child or the children that are living in these low-income households, as well as promote a positive and responsive mother-child interaction, and also increase maternal self-efficacy. The other piece that I also wanted to highlight as well is that we'll be launching this in February, and we will be doing this in partnership with Connections Early Years Family Center. They've graciously allowed us to utilize their site and to launch the program, as well as provide childcare for us. So I wanted to, mention that to the board and indicate that we're very appreciative for the partnership and the collaboration. More details about the program can be found in the report, but I'm happy to answer any questions that any members of the board may have on this.
All right, thank you. COVID-19 surveillance and epidemiology. Nicole, anything you want to highlight in that report?
No, I think Dr. Nesbitt captured most of it in the beginning, so I won't rehash it, but certainly we can answer questions if there are more.
All right, thank you. Okay, Q3 reporting. Lori, now you're on.
All right, I'm going to share my screen, please. And just hold on a sec so I can actually see everybody.
Yep.
Thank you. Okay, so the Q3 report was submitted earlier this week. It addressed the Q3 standards activity under the mandatory programs, and as well it looked at the COVID expenditures, both the response side that the terminology we typically use is COVID response, as well as the vaccination side. So I wanted to highlight just the key metrics. So from a budget perspective for 2021, we anticipated that the mandatory program would have a budget of total net expenditures of $21,615,426. The prorated amount, obviously, at September 30th would have been $17.6 million. Our actual expenditures, however, were $10 million. And that is really a function of the reallocation of the substantial amount of our resources from mandatory programs to support either COVID response, and that's the case and contact management, the enforcement pieces, or COVID vaccinations. For the forecasted December 31st year end, we anticipate that expenditures for the mandatory programs will amount to $14.1 million. Continuing on with the Q3 standards report, the Ontario Seniors Dental Care Program, our Ministry of Health approval for that program is $1.6 million. At September 30th, the actual expenditures amounted to just over 1.1 million, and we anticipate that forecast expenditures through the end of the year will be 1.7 million. And the driving force behind the increase in the total expenditures as compared to the budget is really the increased additional human resource capacity to address the increased demand of the program. It is our understanding, based on preliminary discussions from the Ministry of Health, that the excess of $49,662 will be provided in additional one-time funding, and an approval that should happen either later next week and or in the beginning of 2022. Under the mandatory programs as well, there were two one-time 100% funded business cases that were approved by the Ministry of Health. The first being associated with public health student practicums. We were awarded a grant for 2 practicum appointments. And as well, we received an approval for $1.9 million to support the School Nurses Initiative. These nurses help with the rapid response and support with the schools. So for the September 30th, as you can see from public health student practicum, there were no dollars spent, and we don't anticipate spending any dollars under this funding envelope by March 31st, 2022. From a school focus initiative, actual dollars spent as of September 30th amounted to just over $1 million, and we anticipate that by March 31st, the totality of this grant of $1.9 million will be expended. In regards to COVID expenses, and as some of you may recall, the budget that was put forward both from a COVID response perspective and a COVID vaccination perspective was done very preliminarily with limited information. And again, we've seen the various changes with COVID all the way through fiscal 2021. The budget was 3.5 million, and it's certainly not reflective of total expenditures that we have incurred. So at September 30th, we're at 3.7 million having been incurred, and we anticipate to be as high as 6.6 by the close of the year. Again, substantial human resources are being allocated to support these programs. Additionally, forecasted expenditures include 550,000 of certain other labor matters being resolved for year end. And as well, we see roughly $300,000 worth of cost being incurred in the latter part of the year with third-party supports for case and contact management, call center, and finance. Additionally, we're seeing that we will have roughly $85,000 worth of IT and IT-related expenditures. And lastly, from a COVID vaccination perspective, again, with the very limited information that we had during the budget time, we had budgeted $5.4 million. Actual expenditures at September 30th were 7.3, and we forecast that expenditures will grow to 8.4 by the close of the year. Again, we continue to, since September 30th, we continue to support the Sears site, mass vaccination site, and as well, there are various mobile efforts that are occurring throughout the Windsor and Essex County. So that is a summary of the expenses as currently reported to the Ministry of Health. The Ministry of Health will be looking at our Q3 report and identifying whether there are any funding gaps that need to be addressed with one-time funding, and hope to see some sort of an approval, again, probably more so in the new year related to the 2021 fiscal year. And stop sharing my screen.
All right, thank you, Lori. Any questions on Q3? Okay. November communications recap. Eric, anything out there? I think it's more for information.
More for information. The only thing that I would note is a sharp increase in our website traffic. Usually that's a result of increased eligibility in the for the vaccine, which was the case for third doses, or a rise in cases, which we saw both.
All right, now we'll move on. New business 8.1 project governance committee in terms of reference. Nicole and Judy.
So I'll start, and Judy can certainly add. So just for the board's information, we've restarted our project governance committee. I think we voted on that I can't remember what month now, they all ran together, it might have been in October. So we did update the terms of reference, and they are, they hadn't been updated in quite some time. So they are in the board package, and as well, it required a new chair. So the previous chair was a provincial member who's no longer part of our board. And so Judy agreed to be co-chair of the project governance committee. So which we're all very thankful for. Yeah, so we just have the updated terms of reference for the project governance committee that we're hoping the board will review and we can approve. Judy, do you want to add anything?
Not really. I think it's a lot of work to do, and we're going to get on it.
Okay, so I motion then to adopt the report. Reno, Judy, all in favor? Opposed? That's carried. 8.2 Board of Health, our meeting schedule for 2022.
Yep. So
just a motion. Nice motion, and I think it's really status quo. So moved by Joe, supported by Judy. Our meeting schedule 2022. I've got a hard time. I'm still trying to figure out 2021. But anyway, all in favor? Opposed? That is carried. Thank you. Move on to correspondence. If I can, okay, we'll start with 9.1, the Algoma Public Health. I believe, Christy, we're looking for support here.
Yeah, so I'll start and Christy can add. The board may recall we did bring forward information report previously. We do have an agreement currently with Windsor Regional Hospital where we've taken over the IPEC hub services, which really are a part of public health. So we have our mostly our PHIs, our environmental health team that supports that work for congregate settings. This letter we support from Algoma, although we would amend and put our own letter forward, but really it's just right now the funding ends in March. We would ask that the ministry actually continue this funding and make it a regular part of our mandatory program funding, and that those funds actually are directed to public health as opposed to the acute care system, given that it is primarily the work of public health. So that's what we'd be asking the board to support. And Christy may add if she has anything. I didn't cover it, but.
Oh, Nicole covered it perfectly.
Okay, thanks, Christy. Okay, with that, any questions or comments, members of the board? If not, then a motion to support the Algoma Public Health letter to Minister Elliott and request for analyze IPAC hub fund. Judy, move, supported by Ed. No further questions or comments. All in favor? Opposed, if any? That is carried. Okay, well, 9.2, I think at this stage here, I think they're in negotiations. I think they've restored to children and seniors. And so I would hold that one certainly in abeyance and just receive that information. So that's moved by Reno and supported by Joe. All in favor? Opposed, if any? That is carried. Thank you. 9.3, the Town of Essex, letter to Dr. Nazateri and Nicole. And I think since this letter's been written as well, I think there's been other direction from the province. So I would say at this stage here to receive the letter. Joe and Ed, all in favor? Opposed, if any of that is carried. We've dealt with committee of the whole members of the board. So I'll ask, is there any new business that the board members want to bring forward? Or administration? Hear none. Then as the board chair, I just want to extend, this is our last meeting for 2021. All the best to each and every one of you and to the viewing audience. You know, season's greetings, great holiday, relax. You know, encourage folks to be safe. Keep your gatherings low, and keep your obviously your cohorts, you know, and close to you, and but most importantly, enjoy some time off, and in particular to administration and to all our rank and file at the health unit. It's been another really tough year for all of you, but certainly it hasn't gone unnoticed as the board and certainly the citizens that you help keep safe. Thank you for what you do. And, you know, it's been very difficult getting a lot of backlash from some folks, but we certainly are there to support you as a board and to continue to do the right thing. And most importantly, we know in your hearts, you're there for the delivery of good public health to certainly all our citizens. So on behalf of the board and all the communities that you serve, get some rest and come back, I guess, invigorated, and hopefully we can finally in 2022 push this COVID issue behind us in the rearview mirror. And so with that, adjournment is certainly in order. Moved by Reno and supported by Judy. All in favor? Opposed, if any, that's carried. So with that, we bid you a good afternoon, or what's left of it, and good evening, and all the best till we meet again.
Thank you.
Thanks, everyone.